during the EBMT 2020, I was able to give a 10-minute educational presentation about the sequencing of immunotherapy in multiple myeloma. And in this session, we were very fortunate because speakers prior were able to explain the targets, such as CD38 and also CAR T cells and antibodies. And so I tried to sequence, give an algorithm for patients who are being treated nowadays. Today, we are very fortunate since monoclonal antibodies are now being approved and reimbursed for frontline. So thus, either transplant eligible or ineligible patients are now able to receive anti-CD38 monoclonal antibody at diagnosis, and this improves the results tremendously. And in the near future, we will not be facing so many relapse patients as we are facing today. But nevertheless, it's not impossible. So if we start with today's algorithm, with a patient who is diagnosed today, if that patient receives anti-CD38 monoclonal antibody, and later on, if this patient fails therapy, what are the options for such a patient? We know that failures on anti-CD38 monoclonal antibody are patients who lose CD38 expression or different mechanisms of resistance appears. And for this reason, we have other options. We have other monoclonal antibodies, but it's not limited to immunotherapy. So such patients may benefit from a non-immunotherapy-based regimen. But if the patient and the physician wants to pursue with the immunotherapy, we have another target, which is B-cell maturation antigen. For this specific antigen, we have BiTEs and also immunotoxins, and both these drugs are now available, and the immunotoxin has been Blenrep, which is the pharmaceutical name, is now approved both by FDA and in Europe very recently. So such drugs can be used for such patients if they have failed the first and second generation IMiDs and proteasome inhibitors, and also anti-CD38 monoclonal antibody. And what about the sequencing of a BiTE versus an immunotoxin and versus a cellular therapy? Because so far, among all these options, anti-CD, anti-BCMA options, the best looks like to be with the CAR T cells, because the highest response rates are achieved with CAR T cells against BCMA. The durability of the response is the major concern. So the question here is, what happens if a patient, for instance, fails a CAR T therapy? Is that patient going to be still expressing BCMA to be able to receive an anti-BCMA immunotoxin or a BiTE treatment? And so far, we don't have much evidence based on this. We have a few case reports, small studies. One study which was presented by Adam Cohen and his group, they were able to show two scenarios in two patients, with one starting with a BiTE and continuing with CAR T cell, both targeting BCMA, and the vice versa. And in both scenarios, the patients were achieving similar results, so which shows that relapse following an immunotherapy targeting BCMA is a possibility. And still another agent which targets the same BCMA molecule can be used. But in future, we will be having other monoclonal antibodies and targets such as CD138, CD56, and CD74. And so these are all options. But I think the major question here is about the CAR T cell therapy. And CAR T cell therapy, if it is going to be more durable if we can sustain that, such as with adding a dialysis or such drugs, so as to increase the T cell memory capacity, then maybe moving CAR T cells to earlier phases. And then for those who fail on CAR T cell, those patients may benefit for the approval, within the approval penta-refractory cases with a BiTE or with an immunotoxin.